Yes. Over here. It's the CEO. I want to see your lady.
Yes. There is a
Good evening, everyone. Can you hear me? Okay. I just want to say welcome and also offer that we have beverages, food and drink in the back. And help yourselves and get settled. Myself, I'm Dr. Meininger. My partner, Dr. Halver's here. We're happy to talk with you more about it and excited to have you all join us. So take a moment, get yourselves comfortable, get some food and drinks. As a friendly reminder, we are broadcasting it via live link through Microsoft Teams, so people will be joining us remotely. We're also recording it, hopefully post it later for those that might have missed it. And as such, if we could help to be polite or turn off your cell phones or vibrate, it will please. Thank you. Take a moment, get some food or whatnot, and we'll see you shortly.
I probably can update.
Can everyone hear me? Well, thanks again, everyone, for coming. Hopefully, we're able to enjoy the food or get yourself something to drink. Again, my name is Dr. Meininger. I'm one of the sports medicine and founding partners of Steamboat Orthopedic and Spine Institute. I'm happy to have all of you join us today, and we're here to discuss arthritis pain, and I'm joined by my partner, Dr. Howard.
First question to the audience, who's prettier, me or him? Just a joke, just a joke. Turn off your cell phones. We're gonna ask for questions. Raise your hand. Bettina will come around, Forrest will come around, and you guys can answer or ask your questions. We'll try and come up with some answers. Try not to cuss. Yell things, throw things, unless it's at him. Let's see if he hears a little bit. Bobby Howard, orthopedic surgeon. I'm a joint replacement surgeon. Very happy to be here. I am thankful for everyone who put this together. The CEO, the CNO, Brittany, Bettina, Forrest, everybody, Kendra, you guys have been great. Thank you very much. I know we did it kind of quickly. We're very patient. We have some patients here that are going to talk, and we are very thankful for you guys being here.
Yes, thank you so much for coming, everyone. Our goal tonight is to talk, educate, share stories about arthritis and arthritis pain. So I think what everybody came here to say is, what are the details? Who's the who, the what, the where? What is arthritis, particularly to the hip and knee? Who does it affect? What can I expect? And what are my options, right? So what is arthritis? Arthritis is described or defined as the painful onset of joint disorder with swelling, deformity, and inflammation. Arthritis is like the wear and tear phenomena where the joint may degrade or deteriorate. Osteoarthritis is probably the leading cause, and osteoarthritis is that degenerative wear and tear, time-related phenomena. But there's more than 100 causes of arthritis. Rheumatoid arthritis being one of the other most common causes, and arthritis due to injuries, such as meniscus tears or ACL injuries or old fractures that may change the patient's knee alignment or contribute to early joint wearing out. Symptoms of arthritis are going to continue to be pain, swelling, a limp or impaired mobility where getting around with a cane or crutch is often necessary. Pain is obviously the mainstay, and we can use different treatments. We'll talk about more on how to control that. Swelling or inflammation of the joint may manifest with stiffness, that it doesn't want to bend or feel the same, or you can't swing your leg out the car door, or can't tie your shoes and socks as you want it to, that the joint just doesn't move like it's supposed to. Mechanical grinding is often disconcerting to patients where they might feel they can hear their knees as they go up and down the stairs, or crunching, popping, etc. And deformity, and some of you might relate where this might feel similar, that after a hike or whatnot, having to ice the knee or wrap it or use other tools to help keep you comfortable and on your feet. There's a multitude, like we said, of causes of arthritis, and trauma might be one of the leading causes. So in this room, chances are we have more than one ACL tear that's been treated or have in the past. But there's also a genetic component. And while 32 million people in the United States may suffer arthritis symptoms, the genetic component suggests that there's a multitude of other causes. Enzymes or growth factors may contribute to arthritis, and some of these are heritable or maybe passed down. In addition, gender. Women have a higher incidence of osteoarthritis than men, for instance. And age is probably the most common factor. So too many birthdays, right? So wear and tear, that the joint may progressively deteriorate with weight bearing, et cetera. And the incidence after age 45 or up to 65 is totally different story. But that's why we're here to offer help, pain relief, discuss options and how we can control the arthritis.
Dr. Meininger, first question. So I'm 45. My knees hurt all the time. You said 65 is the only time you're going to take care of this arthritis. Does it happen in younger people?
There's a yearly incidence of about 10 per 100,000 persons every year going to be diagnosed with arthritis. So it comes up even from age 26 or beyond, where you can find X-ray evidence or MRI evidence of the cartilage beginning to thin out, the joint beginning to wear down, much like you wear down the shoes on the soles of your shoes or the treads of your tire. Not everybody in their 40s is so advanced that we need to consider advanced or joint replacement options. We have options for you too, Bobby.
Woo! Makes me feel good.
Why don't you share?
So this is a cartoon, basically looking at a normal knee and then a bad knee. So Dr. Meininger talked about, arthritis. What is it? What, for us as doctors, and especially him, the really smart doctor, he starts saying all these genetics and these big terms, but really it boils down to lack of this cartilage, right? So cartilage is the soft stuff in between bones. Every bone in your body that comes together with another bone has cartilage on the ends. And that requires that cartilage to be healthy for it to move. So your knee requires cartilage to move. Otherwise, you feel that grinding that he talked about. Well, this is a cartoon of what happens when you lose your cartilage. We see this in younger people who have gone through trauma or older people that have just, skied their entire life, right? Or done a lot of things, right? Age, right? So a lot of those things, but this is really a cartoon so we can look at it and say, Dr. Meininger is not so smart, but I could look at that thing and say that one on the right is bad. So that's essentially what arthritis is that you're losing your cartilage. We talked about the symptoms. So and then we'll talk about how we treat this from a surgical standpoint and a non-surgical standpoint. Now, I'm a surgeon, right? So I love to talk about surgery. I love to pat myself on the back and say, I'm a great surgeon, but there's a lot of other things that you can do outside of surgery. So this is not a cartoon, but an actual X-ray that shows the difference between a normal space and an arthritic space, right? So how do we say, I don't have an X-ray in my apartment or in my house or in my closet? We have to go to see a doctor to get one of these, right? So we should be getting these X-rays if we're feeling the symptoms that Dr. Meininger described. Hey, I'm having pain on a day-to-day basis, or I'm feeling that grinding, or even, come on, see here real quick. We brought real patients in here today to show off how beautiful we are and how beautiful our community is. This is one of our beautiful patients. She didn't know that I was going to pull her up here today, but we want to see her knees. So one side is straight, the other one is bowed, right? So a deformity is another thing that we talk about. When we see that bows or the knock knees, you should go see a doctor, go see our primary care physician, go see an orthopedic surgeon so that we can get X-rays of that and take care of that, right? Yeah. Yeah. So from a standpoint, when it gets to this, when you see your primary care physician, you say, hey, I need to go see Dr. Howard, not Dr. Meininger, because he does. No, I'm just kidding. Ultimately, we want the primary care physicians, they're a huge part of our community, to see the patients first and get X-rays if need be. And then they'll send us over to the orthopedic surgeon to do further testing if necessary. So in reality, there's different causes of that knee pain, joint pain, hip pain, and Dr. Meininger alluded to them. Some of them is genetics. So sometimes we have rheumatoid arthritis, or we have psoriatic arthritis, we have gonococcal arthritis, those things that attack the joints that maybe to younger people like Dr. Meininger. So, but the workup includes all that stuff, and it starts with an X-ray and an exam, right? So you got to go to, yes, sir.
Back pain and all stuff. I know it's about knees and joints, but there's a lot of people that have back pain.
Absolutely, everyone's got back pain. We've got back pain, right? So the back is the connection to the legs, right? So I've always told patients this: the hip and spine are interrelated. So I can't tell if it's a back pain or a hip pain unless I do a physical exam. So a lot of people will ask me, how do I know that it's not my back? Or how do I know it's my hip? People will come to me and say, yeah, doc, I know you do a good job on hips. You got to replace my hip, and I'll tell them that's their back. It has to be from a standpoint, a physical exam finding. So I could do a quick physical exam finding and say, hey, I know that it's your back or it's your hip. But a lot of that comes from experience, us just seeing the patient. So even though you say, oh, my back is killing me, I think there's nothing can be done. Come see us with research so we can help you. There's other things we can do to help strengthen your core, give you some physical therapy, even anti-inflammatory medicines that can help with your back. But yes, they are interrelated very much, especially with my young lady. I'm using her because she is as beautiful as they come in Steamboat. But the difference between her left leg, which is bowed, and her right leg, which is straight. So her left leg is shorter, and she walks with a little bit. And so we talked today. I said, yeah, you're going to hurt your back if we wait too long to replace this knee, right? Because I can give her pain relief with an injection or activity modification or anti-inflammatory medicine, but I can't change that leg length without a surgery. But in reality, she's stressing her back because each time she steps, her left leg is a little bit shorter than her right. So they are interrelated in every aspect of this, right? We talked about this. Yes. So, I'm sorry I keep you, but I don't.
You're a dog.
I got a date tonight. Other questions? Okay. So this is well, I'll let Dr. Meyer talk about this.
We start with an exam, we get a feel, we get an impression of the patient and what they experience, and we can do those workups and do our physical exam and get x-rays. Like the picture showed previous, it's that joint space we really want to assess. And sometimes it's clear as day, like that picture, that maybe the joint is completely collapsed. Maybe it's not. Maybe we need to dig deeper. Maybe we need to look at the soft tissue and the cartilage. And sometimes an MRI is required, but it's not universal. Oftentimes I spend time defending, well, don't I need an MRI? No, this knee is bone on bone. It's not so bad. We understand what's going on. This is an arthritis picture. Sometimes it doesn't look black and white, cut and dry, and we say, what else could be happening? Then we need an MRI. But it's not necessarily 100% of the time, and we presented this at a national conference years ago, but it may be helpful in some cases. We have those tools available, and we can discern if that's something we need to do or not. As muscle atrophy, stiffness, weakness are another thing that we want to address. So not only the limp, the back pain, or the deformity, but predictors of your success rate with surgery, if it gets that far, include the deformity, the position of the knee, or atrophy or weakness in the knee. If you let it go so far that one thigh is shrunken compared to the other, it's going to be hard to regain that, even if you recover from surgery with 100% success. So there are some elements to discuss in terms of how much muscle strength we have, how much functional deterioration we're looking at. And that speaks to the deformity, the bow-leggedness, but also contracture. How much does the knee bend, flex, extend? And it doesn't match the other side. The chance of getting the artificial one to do the same may be similar, and you could have let it go too far. So to optimize the outcomes, we want to look at all these predictors and say, which patient's going to do best? What knee looks like it needs it? When is the right time? It's kind of the question that we want to help you answer here today.
There's some things we cannot fix. So we can make the leg straight. We can make the joint normal again, but we cannot fix muscle atrophy. So we can't change that. So let's say you've had knee pain for 10 years and you come to me and say, you know what, doc, I'm ready for my knee replacement. But my quad is so much smaller than the other side. I can't fix that. I can't give that back to you. You have to go gain that. And if you've lost it for 10 years because you're afraid to come see a doctor, afraid that of Dr. Meininger's head, the glare, it's all right. He's not really bald. He's just aerodynamic. We can't fix it all. That's what we're saying. Is we want you to not be afraid of us. We're not going to automatically say, hey, surgery, surgery, surgery. But we can give you things to do that you can be successful later on. But there's some things that we cannot fix.
So we have a patient with knee pain. maybe they have a deformity where they're more bow-legged. What are my options, right? That's what everybody wants to understand. How do I feel better? How do I comfortably get my ski boots off at the end of the day? How do I stop using these ice packs or reaching for my prescription medication? So one, exercise strength. Like we emphasize now, we want to be as strong, as fit as possible. Evidence shows that building muscle mass, increasing aerobic activity can not only enhance cardiovascular health, but can reduce arthritis from worsening, slow progression, and delay onset. So those are long-term studies that people might have heard of, like Framingham study looking at following people for 30 years. Those are active, may have had less knee arthritis than those that weren't active. We can maintain a healthy weight. So just like the struts on our cars, they're designed to bear the weight, hold the burden. If we have extra weight we're carrying, those joints are forced to bear it. If you do those complex physics drawings and free body diagrams, you can say that the kneecap has to bear 4 times your body weight every time you rise from a chair or step up. That means for every pound you lose, your knee feels like you lost 4 pounds. 10 pounds is 40 pounds. So weight loss is an exceptional tool to help us relieve knee pain, increase function, and make you feel better. And it can go hand in hand with that cardiovascular exercise. The more we exercise, the more strength we build, the more calories we burn, the better my knee feels. So those are the simple tools, and we can kind of help reinforce that and say, well, Bobby, I know you're 45, but you're not active enough.
You're not strong enough? You're too fat? You don't take enough medicines.
So if we tried those things, and what other options do we have? So the prescription pad, right? I'm a doctor, I've got pills, I've got needles, I've got scalpels. So where do we start? Let's start with the simple things. Ibuprofen may work well. We have other tools like prescription medicines and naproxen, Celebrex, diclofenac, or Voltaren, and they all roll off the tongue, and we have different tools for each of them, and they have different safety profiles. But reducing the inflammation, taking down the swelling can be as easy as taking prescription medications, maybe pre-treating a powder day with a couple anti-inflammatories, or recovering from a long day on your feet, errands, or the golf course by taking medicines to help you be more comfortable. Medications are common, so are supplements. So maybe I'm averse to ibuprofen, doctor. Maybe I want to try something different. Turmeric, curcumin, the active ingredients in anti-inflammatories are proven to have efficacy, reduce inflammation just as well as ibuprofen does, and maybe just as effective. So I have no argument there. Other tools like dark cherry juice may similarly, and supplements like vitamin D. Vitamin D deficient patients may have higher onset of arthritis or progression of arthritis. So working with your primary doctors, understanding vitamin D levels can be helpful. Maintaining those, taking supplements can help keep your arthritis at bay or maybe keep it from worsening. Maybe you'd have to have fewer appointments with Bobby if you do that.
But everyone in this room can do stuff that's on these slides, right? So even without a doctor, without a big brain like Dr. Meinecker, you can do all this stuff. Lose some weight, eat better, go to the gym, exercise. We are in Steamboat Springs, one of the healthiest environments in the world, if not, I mean, I think from a standpoint, we all want to be active, right? So going out and hiking, skiing, all those things are good for your joints, right? Yes. So all those things up here you can do even before you come see us, right? You don't need us to tell you to lose weight. Then you get mad at us and say, oh, I didn't read it. But these are all things that you can do, right? And talk to your friends, talk to your family. What have they done? What have they done in the past? So all that can help you back. And a nice moving glass presentation. This is the UC Health thing, so.
I get that question sometimes about diet too. So like the supplements, there's evidence an anti-inflammatory diet or even a meatless or plant-based diet can help reduce arthritis. Some of those studies are more new and we don't have the long-term 10 or 20-year results. But serum studies looking at inflammatory markers, looking at joint markers, if you draw the fluid and say, is this joint inflamed, is that? They might be less in those patients that have less inflammation. It's just natural to have fewer processed foods, more natural foods. And if a more natural diet or a plant-based diet is in your interest, you're welcome to try or give it a 30-day trial. If that reduces your pain, then I'd stick with it. It's not for everyone. Perhaps healthy fish instead of red meat diet is appropriate, but changing what you consume also can alter the way your body feels and behaves and performs for you.
So with every slide that we put up there, I think from a standpoint, we like to bring examples of what how it relates to you. So this is a real patient. We obviously can't give a name, but we want to give a scenario for you so you understand what we do and how we do it. So this is a 62-year-old male. He rides his bike almost every day with no pain. He has that deformity that we see. So bow legs, right? He can't hike anymore. He's taking anti-inflammatory medicines. He takes ibuprofen 6 times a day. That's not good, right? So that's the first red flag to us as doctors that said, what you're doing something, you're over medicating, right? So you're hurting your kidneys. You're staying active, which is something we want, but you're hurting your kidneys and you could potentially cause problems later on. So when he comes to see me, he's like, I do not want surgery. I do not want to talk to you about surgery. Give me something else. Then, well, first you got to quit taking the ibuprofen so that you're not on dialysis one day. So from a standpoint, it's a give and take. We as surgeons, our doctors as well, we want to help you as much as possible. We have to understand that, all right? So these are his x-rays, right? So there's things that we can do that Dr. Meininger talked about, bracing, right? Anti-inflammatory medicines, a good diet, lose some weight, staying active, building muscle is actually very helpful for the joints. The stronger guys and gals protect those joints a little bit better, okay? So going to the gym, especially in my older senior females, my beautiful females, lifting a little bit of weight, the bones. As you age, estrogen, progesterone increases your bone density. So keeping that bone density up by lifting weights is very important. Okay, so here's his x-rays, right? So this is a classic x-ray that we see, bone-on-bone arthritis, right? He's got gapping here. He's got his varus deformity, which is the bow-legged deformity. Well, we try injections. We try injections for years, and you can do injections. There's 3 really types of injections. A cortisone injection, it's not the Barry Bonds steroid, but it's a corticosteroid that basically treats pain, and it's an anti-inflammatory that goes inside the knee. There's also a viscosupplementation injection, which is kind of like oil for the knee. So it's something that lubricates the joints. The cartilage is, when you lose cartilage in a normal knee produces oil for the knee that is normal, that makes that joint move nice and smooth. Well, we're trying to put that in synthetically. The other injection is a platelet-rich plasma where we take your blood and we inject it back in the knee. There's a lot of studies on all this. From a reality standpoint, about 25 to 30% of people, it helps greatly. But sometimes I get steroid injections for 8-10 years, and that's what the patient needs, right? They're not healthy enough for surgery. They get 6 months of relief with the injection. They're able to do what they want to do without taking ibuprofen for 6 times a day. All of that, you need to talk to your surgeon, your doctor, about how best to treat you. Also bracing. So if I put a brace on the outside that pushes that knee back into the middle, it's going to take pressure off the inside. So we call that an offloader brace. You need to get that from an orthopedist though. And we have specialists that will fit you for that so that it's comfortable. So that you can go back and ski, okay? But sometimes that doesn't work. So, well, sometimes we have to do surgery, right? Sometimes that happens, but we want you guys to see. So we are very fortunate to have Mary Jo in the back there who does all our data collection. Yes, Yampa Valley, we are in the 21st century. We collect all these patient-reported outcomes. Each patient that had surgery here gets a phone call from the beautiful Mary Jo back there and says, hey, I need this from you. How did you do? How did we do? How do you feel? Those things are very important for us as surgeons to determine how we're doing, right? How you guys are doing, how successful it is. What can we do better? How can we be better? What things was successful about that study, right? So a lot of the data that she's collected, we put in these slides. So really, the most important thing that you can see is joint satisfaction after a year, 89%. That is a huge number. National studies are somewhere between 70 to 80%. So Yampa Valley, they're doing better than the national folks. I mean, this is what it boils down to. And then your 3-month satisfaction is 92%. These are huge numbers. Yes, sir.
And these statistics include the surgeries done at your surgery center.
Yes, sir. So we collect hip scores and knee scores. These are ultimately very important for the future from an insurance standpoint. We're gonna have to present these numbers to insurance companies to get paid. But it's also important for surgeons to realize what we did right and what we did wrong. So I'm gonna bring a patient up here real quick. She's eight weeks out from surgery. She doesn't know that I'm bringing her up here right now. But all I want to do is, before you get nervous, is, she just had surgery.
That was 8 weeks ago.
I know, 8 weeks ago, 2 months ago. Tell me, how did it go? Wait, what did you do today?
Went hiking with Mary Jo, with the beautiful Mary Jo. And I rode my bike, my e-bike, to Frankfurt. There we go.
Yes. So
So,
how was your experience here?
well, so I'm fairly active, but the several months leading up to surgery, the end of the ski season, I got to where I couldn't ski for 2 or 3 hours. My hip was very painful. And then I normally go to Texas and run on the beach, and I couldn't run. And then I came back and I couldn't hike. I could ride my bike, my road bike, which was great, except afterwards it was not great. So the whole time out there, you're thinking, I'm going to pay for this later. And so as I got further and further into the summer, my activity level went down, down, down. It got to where I felt like I couldn't do anything without pain. I couldn't walk half a mile without pain. And Dr. Howard said, well, you've got osteoarthritis and a torn labrum and I don't know, a whole raft of stuff. And
Well, the first time I met her, you could tell that she was distressed by the first time I met her. Yes. And she was afraid for her active lifestyle to go away. So, her questions to me were, is this always going to be this way? And you could tell right away that she was distressed about what her future was. And this is a classic steamboat patient. She's active. I want to still be active. I want to keep hiking. I want to keep riding my bike. I think it's important for you guys to realize that there's real people right up here, 2 months out from surgery that did great.
well, yeah, so so it was very painful pre-surgery, and I went in and Bettina and Kendra and everybody was amazing, amazing, amazing. And I was terrified, and I went in at 6 a.m, and by 6:30 I was fast asleep and woke up a couple hours later and it's like, wow, that feels way better. And 2 days later, I ditched the crutches and the walker, and I was going up downstairs. And I think on day 4, I did a half-mile walk around my block. And a week later, I was on the phone with my physical therapist saying, can I get on my e-bike? So really, like, zero pain compared to where I was. So it's a good surgery.
Yeah.
Well, I feel, Dr. Howard, I think these surveys are introspective and helpful too, right? You get an email that says, well, how's my function today? You're like, well, it was 4 days I walked a mile, 2 weeks I walked 3 miles, and then maybe, Jackie, within how many weeks?
Just a couple months.
Yeah.
Well.
I got photos back from Europe, right?
Yes.
You can tell them if you want.
Went and had my surgery on my knee October 12th, and April 16th, I went to the Balkans. And Balkans is called, some of the cities, especially Dubrovnik and so forth, city of steps. Up, 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 down, 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 hills, cobblestones, no trouble at all. It was just a miracle.
So surgery, it's a great surgery. It's a functional surgery, but it has to be right for you. Right? So we don't want you to be afraid of the surgery, but we want to understand that it is part of the treatment algorithm. As surgeons, that's what we look to tap, that's what we do. So I don't know if the pre-op x-rays came through, but that's what you can get. So this is another patient. He came into my office, cranky, steamboat guy. Said, I went to Vail, and they said, I need a hip, and I want it tomorrow. Well, can't do it tomorrow. The 71-year-old male, very active, skis 70 days a year, gets on his bike, is taking CBD for his pain, not any anti-inflammatory medicines, a CMO native. So he texts me 2 weeks ago, said, I'm in London, I'm not making my 2-week post-op, I'm good. I never used the crutches, never took a pain medicine. He's 4 weeks out now in London, eating food. So, I mean, the hip surgery, the knee surgery is fantastic. It is, our goal is to get you moving and up. And we want you guys to have a successful story. We want you to be that functional. We want you to keep you active because this is an active area.
But these are replacements.
Yes, so he had the right hip replacement. I didn't get a post-op film because he hasn't come back. Working in London. Yes, hip replacement. So these are just so. Obviously, we worry about complications, right? So surgery in themselves, just because I say you're going to have a surgery doesn't mean you're not at risk for some complication. So infection, dislocation, failure of the implant happens, right? So we're afraid of that, right? And people ask me all the time. I saw a 40-year-old today that we both saw today. He's like, well, what about a revision hip? What about a revision knee? Well, nowadays, the revision aspect of things from a functional standpoint is very great. So we have Miss Mo here who had her hip revision. Why don't you tell us about your experience, Miss Mo? No.
You saved my life.
Well, I know, right? So Miss Mo came to me really after having about 6 months of pain. No one could really figure it out. They live in Craig, very active lifestyle before, and really couldn't be active. Her husband is always home with her. They are retired. They want to be active, and she's like, something's wrong. Tell me what's wrong. Fix me. And I think I don't know how many surgeons you saw. She had her hip replacement done on the front range. And no one really could tell her what was wrong.
It didn't work. It was only 4 years old and it started coming apart. And I went to several different people for help. It got to the point where I could move my leg an inch without screaming. My husband kind of kidded around and said I could probably try out one of those Hollywood movies with the screamers. Like, I think I screamed in my life. I screamed a lot. And I was misdiagnosed by somebody else that said, what's your IT band? I'm thinking, I can't move my leg an inch without screaming. I couldn't move. I got to know my recliner really well. And finally, I got a referral to Dr. Howard. The best thing that ever happened to me was to see him. And he was the only one who cared enough to go, we need one more test. But I kind of think we know what this is, but we need one more test to rule everything else out. And the implant was loose. It was loose in a couple of places. And I can't even put on a scale of the pain that I had. And when I woke up, I saw his smiling face. And he's like, no ETO. I was so happy and getting to the hospital or going into recovery and getting to the room. I felt so much better. That horrible, horrendous pain was gone. And he's hung the moon for me. My other implant is failing too, so I'll see him in a couple months. And it's going to be so much easier because I'm not going to have to go through 2.5 months of not knowing what it is. And really, they told something wrong. And when he told me today, I'm like, that's fine, I can do it. I let him trust me. I had no worries there. Kendra was wonderful. She took fantastic care of me. It was before I gave my sister-in-law. There was an ICU nurse and the breast health navigator in Texas, and then have surgery. And I gave her Kendra's notes before, during, and after surgery. And Dana's like, I didn't know any of this. And I've been a healthcare professional for 40+ years. So
Well, we brought it up here to realize that sometimes we make mistakes. You know, I'm not God. He's not God either, right? So we make mistakes in the whole process. Surgeons make mistakes, right? We don't like to admit that we make mistakes, but we are here to solve those problems. If you give us the chance to solve them. Sometimes you don't like the tests that we order, right? But ultimately, we're here and we have the specialists here to fix them. So from my standpoint, I wanted you to understand that complications do happen, right? So they happen, you get dislocation, you get infection, you get looseness, you get failure of the implant, we can fix it.
I lost 47 pounds too.
Yes, ma'am.
It seems like everyone that I run into who has had a knee replacement recently is having much quicker recoveries, better outcomes than those that were performed 20 years ago. I'm an example. So is there something to account for that? Is there robot assisted?
Surgeons. Well, that's a great question, right? So the implants are a little bit better. From a joint replacement standpoint, this is a huge industry, right? So Dr. Meininger talked about the amount of people with arthritis, but the implants are a little bit better. The metals are the same, but it's the plastic portion that's a little bit better. We used to say, hey, these last 15 years. Now we're telling people to ask 10 more years, right? So I think the other thing with recovery aspect, 10 years ago, we do a hip replacement, you stay on bed for 3 days, you don't get up, you don't get moved, you got to stay there. Now we get people moving an hour after their surgery. So we get them doing stairs. Barbara was doing stairs an hour after her surgery. I mean, the sooner we get you up and moving, the better off you do, right? And with knees, you got to move that knee. The sooner you move the knee, the better off you are, right? And we can't do the rehab for you. We can do a perfect surgery, and I tell my patients this, you got to do something. We got to be in this together.
Right, well, given that's the same, I was highly motivated on my previous piece.
Yeah.
But again, I see people and a week later, they're in PT, and there's hardly any swelling,
Well,
very
evolution,
little blood,
smaller incisions and able to leave muscles intact and not have to cut the tendons or approach the hip through different means. People might read, well, I had a posterior hip maybe 20 years ago. Maybe we don't understand the difference between anterior and posterior. It's front and back. Dr. Howarth and I are both surgeons who prefer the anterior hip replacement. So an incision on the front of the hip causes less muscle trauma. It's less invasive, a quicker recovery. People are on their feet. The same thing's true with the knee. Smaller instrumentation allows us to do it through smaller windows of surgery. Better partners to work with. Our anesthesia team is evolving just at the same rate we are. They have better tools, protocols, standardization. Mary Jo sees these things, watches our outcomes the same way. Anesthesia can be done with a simple spinal injection in your back. Wears off in 2 hours. You're up standing in the surgery center. Maybe you were walking out the same day. It's different than it was in the hospital 20 years ago, right? Medications we can inject. Nerve blocks are helpful. Ultrasound helps them put them in the right place. All these tools work together. So it's a team approach. Our primary care doctors look at you and say, we got to change X, Y, and Z. So you're ship shape. So you're perfect, ready to go. Our anesthesia team looks at you and says, this is the fastest way you're going to recover. This is what I recommend. We'll take good care of you. And then an expert surgeon puts it in straight, and hopefully it stays and lasts and is secure. So these are the things that can help keep us comfortable.
Isn't that kind of the whole way the medical profession has changed? Instead of having you lay in bed for a week or two, you get them up as soon as possible so the muscles don't atrophy and the brain doesn't atrophy.
Yeah, movement is medicine, right? That's what we do. We want to keep you moving. We want you to be active. So same thing's true in recovery. If you're up, standing, walking, contracting your muscles, you're circulating blood flow, you're reducing your risk of having blood clots, you're opening the airways, keeping pneumonia at bay. These were problems we dealt with in our training, not 10 or 15 years ago regularly. So-and-so's in the hospital with pneumonia. So-and-so has additional blood clots. Now they walk out of the surgery center and blood clots are 1 in 1,000 now or less. So I think advances, just like you said, and the way healthcare has evolved have helped us treat better. And like Dr. Howard alluded to, we're lucky we have good, motivated patients, right? They help keep our outcomes to be as good as they are because we're fit, we're active, we want to ski. This isn't a matter of couch potatoes who want to use the remote control. These are people that want to get up and out, right? And whatever your passion is, if it's walking 9 holes or skiing 100 days, like we're here to help and we can expect what those are and see what you need and how we can help you meet your goals. Heather? That's a great question. Dr. Howard alluded to it.
Here,
Well, what was
The question asked was, how long can we expect a knee replacement to last? It's a mechanical device, right? Like the treads in your tires or the pistons in the motor. It only has so many cycles. We want those to be lubricated, smooth, and last as long as they can. So if we get modern prostheses and technically expert application that's put in straight and has good alignment, your recovery's fast, we expect they should be 20 or 25 years now that knee replacements are lasting. That means that plastic bearing has treatments to it. They use radiation at the factory. It helps the carbon bonds link together. It makes it more durable. They put vitamin E in the plastic. The antioxidants reduce those free radicals from deteriorating the plastic. We can look at x-rays from our patients that come in with surgery 20 years ago and say, oh, this is probably the old plastic, or that's why this eroded early. And we're not seeing those same things now. So those advances are giving people better outcomes and hopefully higher expectations.
But hey, Ms. Donaldson, how does your knee revision work? Yeah, that's the biggest question, right? So you can only do this a couple times, right? So that's what a lot of patients ask me. Well, the knee revision isn't going to work as well as my primary knee. We have one here in the audience that she probably doesn't want me to tell her, but it's a perfect example. She's young, very active, but her primary knee wasn't working. She has a revision now. What is the revision? So if your knee fails, yes?
if your knee replacement fails?
If your knee replacement fails, you get another one. So that's the biggest change in the last 10 to 15 years is the function of a knee revision. It used to be we had to bone graft and cast people after a knee revision. Now we treat them just like a primary. From a function standpoint, I want her to walk the same as if I did a primary knee. I want her to move her knee the same. From a functional standpoint, they work just as good.
the revision, is that different from a replacement?
Right, so a revision replacement. If you had your total knee done 10 years ago and it failed and you needed a new one, that's a revision. A lot of people are concerned about, hey, I don't want to do this until I'm older, so I don't have to get a revision done. A lot of people, even coming from the military, I'm doing knee replacements and hip replacements on very young people so that they can keep being on active duty, but sometimes their joints fail. We change that out to a new implant. That's what a revision is.
I do set up alarms now, though, I have to say.
It's a little bit bigger than a flash, but it's all inner bone. Yes, ma'am. You come see one of us. I mean, so knee replacements, it's a mechanical device, right? So it's plastic and metal. It's going to click, it's going to pop, it's even going to slide a little bit. It really shouldn't hurt a whole lot. It shouldn't feel, some people describe it as, no, it's there. And there's moments where it may have a twinge of pain, but it should be constantly pain. And really, I tell patients, if your knee swells, it's telling you something. If it gets bigger, at the end of the day, it's telling you something. Yes, sir.
On a revision, do you take out the parts that are in the femur and the hip, or do you just put in like new pads where you were talking about the new ones last bit?
Yeah, there's different types of revisions, right? So in a scenario where if the medical components are done correctly, you can just change out the plastic.
Power springs. Oh.
Don't talk about it.
With you? Doing it after.
I think it's,
I mean, I'm happy to because you were my godsend. I brag and boast about Dr. Howard to everybody who listened. Me too. Yeah. I had a revision done because my first TKR failed because the original surgeon forgot to cement a part
together with my phone. So I'm a 23-year veteran of the National Ski Patrol, and I was actually on an incident and my knee buckled and literally flipped backwards. We discovered that it was because the part of my tibia was not sticking. So we did TKR. The recovery was faster, easier, better. And I don't know what to say.
Sometimes things happen. So we don't, we weren't in the surgery. We don't know exactly what happened. But nonetheless, it's a mechanical device. Things fail. This leg on this chair will break one day. We don't know exactly why, but those things happen. Yes, ma'am.
I'll change the subject a little bit. I had a traumatic injury to my right knee, and I have a plate with 7 springs in it, and I built up to be a plateau. So I guess my question is, and I kind of remember somewhere in the discussion that we had during all this, is arthritis something that I am more susceptible to now with this?
Correct. So that's a different variant, right? So having a break or a torn ligament or a fracture in the joint is different than a joint that wears out from old age or wear and tear or too many miles. So you have to use the analogy, it's like a broken kitchen tile, right? You drop something heavy on the kitchen tile and you can glue a couple pieces together and hopefully it doesn't catch your socks and the tile lasts forever. But if that tile is too brittle and it doesn't work, that's like the joint when it breaks. And so the surface is glossy and smooth. And if you have a fracture through it and it's repaired, but even a couple millimeters are not like you were born with, it's going to be at risk of breaking down or developing arthritis or rubbing raw the other sides of the joint. That's a post-traumatic arthritis, it's called in the textbook. That means your arthritis happened because you had an injury. Your other knee is probably not going to have arthritis on the same scale, but your injured knee is on an accelerated path that arthritis might happen more likely than your other side.
Those same things.
Indeed, it's going to manifest with those same presentations. The knee might swell up, the knee might feel stiff or tight, or you might not be able to walk as far without discomfort or buckling or instability, we call it. Those are kind of the worrisome red flags that say, I think I need my knee to be looked at. In the back.
You guys highlight any one of the benefits or some of the benefits of having joint replacement done here close to home with associated with once somewhere else?
I like to self-promote, you know? I'm going to ask Becky Hyde to do it for me. Yes.
I know you brought up relatedness. I mean, that can be identical, but it can get worse.
Well,
As you get older.
the joint is a hinge, right? And just like a door that's hung plumb, it's going to swing like a normal hinge. But if we develop our arthritis in an asymmetrical pattern, maybe one side of the knee wears out sooner than the other. Maybe the outside part broke and it wore out differently. Maybe because our center of gravity goes through the middle, the inside of the knees are more likely to wear out sooner. So you end up with x-rays like Dr. Howard said. So there's a genetic component. We might be more bow-legged than someone else or may run in our family. And that may predispose the joint to abnormal loading. The pressure upon it might be greater on one side than the other. And it can make a difference. But more likely than not, that deformity, the bow-leggedness or knock-kneed, is because you wore out one side more than the other. Like you wore out the outside of your shoes and they don't walk as flat as they did. Thanks for coming up, Becky.
Sure. So I had a traumatic injury when I was 20, and they told me I would need a knee by the time I was 30. And I had a strange incident happen the end of April, and Dr. Meininger replaced my knee the 17th of May. I came in, and I came in the first week of May and had x-rays done and decided I could do a lot of things, but it's going to end up here. 12 weeks after my replacement, I did 2 weeks of hiking in Switzerland. So that was awesome. And about why doing it here, we have some of the best surgeons in the world here. And it's close. I don't want to drive to Vail. I don't want to drive to Denver. I want to be here. If something happens, if I'm prone to weird stuff, So Lord knows, Dr. Johnson can attest to this, but I want my doctors here. And we have such an amazing facility and access to these doctors that world-class athletes are, treated by. Why would we go anywhere else? So I would, Lord knows I've had enough surgeries for most people in this room, and I would come back here every time, regardless of where I lived. So, thank you.
You know, I've operated a lot of places, and I tell the CEO this all the time. I think that from a standpoint of being in the military 25 years, they didn't pay me anything. I jumped around just trying to have 5 daughters. I got to pay for these weddings and colleges. It's a lot of hospitals, and I think Napa Valley is fantastic. I really do. And I think a lot of people have asked me many times, well, what about the infection rate? Well, that was 17, 15 years ago. I can tell you right now, I'm on the board to look at all the infections that come through here. In the last year, there's been 2. I mean, the volume that we do here and the work we do here is fantastic. And I think that from a small facility like this, the talent here is incredible. And I would stand behind the nursing staff here, the anesthesiologists. I think it's fantastic. The occupational therapist, the physical therapist, the team, I'm pretty, I mean, I think from a standpoint, it is, fantastic. And I don't think I would come back here if I didn't think the talent was so good. And the complicated stuff that we do here, I mean, I've done over 50 revisions this year alone. That's a huge number at a small facility. But I don't think that I would do that many if I didn't feel supported.
Stand up and say, hey, man. Here for 51 years, and I know Alice, and I know I've worked with you, but most of the time we have on. I go to Arizona in the wintertime, and I have worked down there for about 4 months, but I make sure I saw some of you guys concerning my stuff, and it's like, I make sure I get taken care of before I do.
How many knees do you do every month?
Well, that's a good question. So I'll do 800 joints this year. I don't know how many Alex does. I just keep track of the joint replacements that I do. And in comparison to what that does across the country, I'm probably the top.
I do probably 500 knee operations at this hospital in addition to the knee or the hip and shoulder operations. So over 150 knees a year, maybe 75 to 100 total hips again. And thankfully I have a partner I can unload some of the complicated ones too. So we can work together that way.
Yes, ma'am.
They were doing for 7, and they said I had tendonitis and they gave me a brace. I went to the brace for 2 months, didn't do any good. So I went back and I said, no. So they looked at the x-rays again and we did those. Said I have arthritis right here. And there's nothing that I exercise and I just ignore it. Just do my daily routine. Isn't that kind of what you want to do with the arthritis? Minor arthritis is just about being active.
Staying active is important, right? Sometimes from a deformity standpoint, if that arthritis is changing the way that your wrist looks or your knee looks or your hip looks or your back looks, or you can't do what you want to do. So oftentimes I tell patients I can look at an x-ray like this that's really bad and they can do everything they want to do. There's no reason for me to do surgery on it. If you're doing everything you want to do and it's not slowing you down, there's no reason for surgery. Or there's no reason from a treatment standpoint that I need to upscale your treatment. You seem to be doing whatever you want to do. Now, if you're in my office, there's a reason why you're in my office, right? You spent the time to come down and see me, and sometimes I have to pull it out of patients like, okay, well, yes, is your wife here? Because you told her the other day that she wouldn't, mow the lawn because you're out.
Excuse,
Yes. Yes, sir.
If I have, inflammation in my back, would it be the, I mean, I've had it for 10 years and I do stretch and acupuncture and blah, blah, blah. Who would be the best person to talk to about that?
That's a good question. And thankfully at SOCI, we have a broad-based practice. There's 10 physicians and surgeons there. We have a whole team dedicated to spine with nurse practitioners and physiatrists and non-operative back specialists, spine surgeons and spine surgery assistants. So oftentimes it works up itself or it's a snowball effect. We want you to see the workup to begin with our non-operative team. Maybe our physiatrist, our Dr. Sloan can look at your back, get x-rays, get an MRI. Perhaps even Dr. Sloan or Dr. Siegel can offer you a cortisone injection, reduce that inflammation. And you never have to meet Dr. Solatiky, who does spine surgery for a living. So we have options, and I would recommend you see Dr. Sloan and one of our.
But you could see any one of us and we'll put you in the right direction. So we could throw a whole bunch of names out and you come over and see anyone over at SOCI, we'll put you in the right place. So, you know, a lot of times as patients, you don't know who you need to see or what you need to see, but we do. We know who the specialists are. Yes, sir.
Get a good peep rating. So
Yes, I can. Absolutely. Anyone else? Yes, sir.
Are all knee braces the same? Are there some we like better than others? Are there some we should absolutely stay away from?
Well, no, they're not all the same. And it depends on what you're feeling. If you're feeling unstable or you have a deformity in your knee, all that is variable on the exam that we see. So if you can get a knee brace off of Amazon, that may not be treating your knee the way it should be treated. So we really like you to come see us so that we can really fit you for the brace, assess you for the brace if need be. They are all different. They can push your knees in different ways.
Later.
Give an anecdote again. John, I see you in the audience. Do you mind talking?
Dr. Meidinger did my full knee replacement about 16 months ago. And he spotted me in the lift line one morning on our powder day this past year. We got to ski the trees together. And I was about 7 months post-surgery. And it was the best thing I ever decided to do. I'm the classic example of having one bull leg and the other one kind of straight. When I was an infant, I was in braces because I was so bull-legged. And to the best of my assessment, my right knee just didn't get quite straightened out enough. So I had all this osteoarthritis in the right knee. And after, 60, 70 days of skiing, I couldn't walk anymore. And so that's when I linked up with Dr. Meidinger. And it was the best thing I ever did. I'm back cycling, mountain biking, road biking, hiking, fishing, doing everything I did pre-surgery. And one of the most important things I want to share with everyone here today is if anyone's considering a joint replacement, these are the best surgeons in the state of Colorado, and they're going to set you up for success. But it's up to us, the patient, to take advantage of our rehab, be committed to the physical therapy. And even I joined the gym after my therapy. All that paid huge dividends. And I'm here to say I'm a happy camper because of these guys.
We want that patient to regain their strength, get the swelling down. Activities like walking 18 holes or skiing or 15-inch powder day, they're variable in how fast you get back, right? If it's just skiing groomers getting on the hill, it could be as soon as 3 or 4 months. If it's 15 inches of powder, like I had the opportunity to ski with John, then that might be 6 or 7 months. And you look at the literature, watch ESPN, Tom Brady took a full year to get back to the NFL, and that was from ligament surgery. So I tell patients have reasonable expectations too. You might not realize the full extent of your recovery until a year passes, and it might not be that that mobility, your strength, or you've forgotten all about your knee until a calendar year's gone by. But it's gradual, and every month hopefully better than the last.
But we want you to ski. You can ski with the hip. These are things that they're, entrenched in steamboats. all those activities that you've done in the past, you can do again.
Could you talk about arthroscopic surgery for meniscus tears?
I love almost nothing more than arthroscopic surgery. The meniscus is the cartilage cushion, right? It's the padding, it's the substance inside the knee. So it helps protect this cartilage. And persons that have meniscus tears or meniscus surgery may develop arthritis sooner. You look at lab studies and pressure pads and you say, if we remove the meniscus, what happens? Well, the pressure upon the cartilage increases threefold, or 300%. So that meniscus is important, but it's a soft tissue structure, a pad stuck between two hard bones. It becomes torn. Its texture is like wet sushi meat. It's not very robust. When it does tear, we have solutions. So if it doesn't respond to exercises, PT, then a simple outpatient surgery like arthroscopy, it's a fancy word for putting the fiber optic camera into your joint with small incisions, can be done to visualize the meniscus, and we can trim it back. I like to say it's removing the hangnail from your knee, and we can relieve those symptoms with simple arthroscopic procedures and hopefully get you back to what you want.
And it's a 6-week preparation.
It is expected it might take you 6 or 8 weeks to get back to 85 or 95% of normal. We have to get that strength back. We have to condition it through rehab. Even a simple diagnosis like a meniscus tear may be prone to developing weakness patterns, imbalances, or a limp, and just the surgery won't fix those. So we need to dedicate ourselves to recovery and the rehab and the strength, and it might be a month and a half before you feel like it's recovered completely. Go ahead.
I just had one more comment that I meant to say before, when I was hearing people asking, well, Front Range versus y'all. And I made that mistake. My sister-in-law that worked at Texas Health, she's like, always go with the numbers. And it was before I knew, about, so I don't think associate was developed yet then. And so I went to the Front Range because of the numbers and the things that my husband and I noticed. One, there wasn't that small town feel, connecting with patients, caring with patients. It really felt more like a chop shop, or just in and out, whatever. And I've had 2 revisions, one shoulder, one hip. Now I'm looking at the other hip revision. But I also made the mistake of going down Valley to that famous place out that way, whatever. And although some of them were very nice, there was such a disconnect between their practice, because I had a neck issue and a shoulder issue and a hip issue, whatever, but nobody talked to each other. And with your practice, I mean, I already saw sliding. I already had 2 disc replacements like that, and it was wonderful. But there's so much more connection with SOCI, and the care, to me, the care between, and I'm not saying this because you're all here or anything else. I tell everybody I know, the care that I got with you, with Dr. Slotty, with your practice, and with the Valley Medical Center, to me, it's the gold standard. I thought Vail was good. They've got that. I'm sorry, they don't. And the other thing about the numbers, I made the mistake of thinking, okay, big numbers means better outcome. And the friend told me, don't ask for the numbers, ask for the outcomes. And so I went to my PT, and I don't think you'll find a PT in the Valley that doesn't sing your praises, probably more than anyone else, because they see your outcomes and they know how good they are. And I wish I had known that approach first, because I never would make the mistake of going to the Front Range and subsequently having to have 3 revisions because I didn't go to the right place. I know I'm in the right place. Everybody here is in the right place. You guys are in the right place. Thank you for being here.
In the back, sir.
I'm 14 weeks out, Dr. Alex, total knee replacement, and I echo I came from Chicago, and I had a small town. I wouldn't go, I researched funds. Totally happy with the whole team. Your front office, your nurses, your everything, the whole experience. I think it's positive.
So Brian,
So I better go.
Can you comment on your experience at the outpatient center?
Yeah, absolutely. Super good experience. Got in. I checked in at 7 o'clock and walked out of the place at 3 o'clock. The what? And just the whole experience was very positive. The nurses were superb. The bedside manner, the anesthesia, the process, the setup, getting laid out on the table. Just pretty comfortable.
Awesome. Thanks. Mary Jo?
It's one thing, being the data girl that I am. When you go to.
Stand up, pretty lady.
When you go to orthopedic surgeons, you ask them about their outcomes. I think that's important. But one thing you also need to know is we have a 90% response rate. So 90% of our patients respond at 3 months and 12 months. So people can collect outcomes, but if you're only getting like 30%, 40% of outcomes, you're not capturing the whole big picture, and we capture the whole big picture. So, and I do it, and we talk to patients, and we look at every 3-month follow-up, we look at every 12-month survey, and if any red flags going on, these guys know about it and take care of it. And there's minimal red flags, just so my 2 cents.
Everyone who works here at this facility takes pride. This is our, this is our town. This is our hospital. If something happens to a patient, we want to know about it. We want to take care of it. If there's some process that we can improve, we focus on. Like Kendra calls the patient, she goes to their houses, she checks up on them. I get an email from her, you didn't do this, jackass. It is like having 5 lives. It's amazing. I get all the nagging, but not the other stuff. You can feel the love. When you walk in the door, you feel like you have, this is my home. I walk down the store, I go to the store and I see, hey, can you just check, well, you're not walking normal. I need to get you into physical therapy. This is why we come to this facility. We're trying to make a hospital that you guys can enjoy, that you can be proud of. And all the people that work here are very proud. You can feel it. Yes.
I feel like one thing that you actually forgot to mention that I think is a really big deal is we try to educate patients as much as we can on these tools and replacement surgeries, because we want you to know what you're getting into. I remember when I first started working with people, I was like, okay, what's going on? What is it about the surgery? What to expect before, during, and after? So one of the things that I really think we really built up on was basically the navigation program, like the team and kind of the surgery schedules, the handouts, the research, everything. So I really think that that's a really important part. It's just knowing what it's all about, knowing what you're getting into, and basically what to expect.
And maybe if you have your question.
Yeah.
But I think it's okay.
3 years ago, we had instituted advanced recovery after surgery with the work of the hospitalist team, the anesthesia team. We figured out the best way to treat these patients to get them in the hospital and recover faster. Instituted a joint navigation team both here at SOCI and at the hospital. So we have multiple fronts that we're trying to make sure that we catch all our bases. Today I asked Barbara, I said, hey, tell me what we did wrong. What can we do better? You know what? I had met her one time. We got her into surgery and they got through all the appointments and everything. She said flawlessly. There wasn't anything that she said, oh, you could do this better. I said, give me something so I can say it today.
I got nothing. It was great. Oxycontin.
Less. But I mean, I think from a surgeon standpoint, and I kind of teased Dr. Meininger a little bit here today, but we care about this city and this hospital, and we want to make it strong. If there's something we're not doing right, you need to let us know, right? It hurts us to our soul if you go to bail. It hurts us to our soul if you go to the front.
Did you hear that? No, it hurts us
I
to
know
our
those
soul.
surgeons,
to
I
go
know
to
they're
the-
good surgeons, but they're not here in Steamboat Springs, and you live in Steamboat Springs. So that's what we want. One of the things that highlight, I think, it's not one of the certain things that doesn't do, it's something that wasn't mentioned, but again, with association, we give back to our community. We're constantly supporting local organizations, the youth here, we're at 4-H, Junior Sports Club and all that. You know, when you go and you're supporting your surgeons here at SOSI, we're supporting the community, of children, grandchildren, and you guys in different activities around town. We, like, again, we want to support the hospital, we want to support our surgery center, we want to support you guys and your families. And come on. Patients can have the surgery, right? But if your surgeon's here, you come here, you can be taken care of. You have your surgery elsewhere, you come here, we don't have any of your records, we don't know what happened in the surgery, what the surgeon was seeing, so any of that. I don't have their cell phone numbers, I'm the guy on call, I can call them up and say, hey, when you were operating on Jimmy, what did you see in me? You know, but these guys, if you come in, I can call them right away and wake them up and say, hey, he's in the ER. But, yeah, we care about our patients here.
Well, yes, please.
I'm not that bad yet. I have the early stages of our problem. And I kind of want to avoid the surgery as long as possible. Yeah, I'm just trying to.
Well, we want to be collaborative. We want to work with you, right? We're happy to take a look, or if
My
you're.
golf swing isn't as long as. But.
So we have these tools, right? That we can try injections or prescribe PT. We can work on getting you stronger. We can make sure you're comfortable on your feet. And we don't treat the x-ray, and just because you have arthritis doesn't mean you need an operation. It's a discussion between your function, your expectations. And if you can live with it, I can live with it. That's fine.
Right now.
So there are options and we can help, and we're not afraid of avoiding surgery either.
Six previous surgeries on a knee that Dr. Wonder replaced in May. And when I showed up, I kind of knew that this was gonna happen because there was a chocolate degree, almost 35 years. And we looked at it and I was presented with, we can try PT, we can do injections, we can do a scope and clean it up, but you know, ultimately this is probably where you're gonna be. They pursued every option with everything I ever had done here. And I will tell you now that in the first time in 35 years, I don't hurt. My back is better, my knee is better, my foot's better, everything. So they are amazing as to, you know, if you don't want surgery, they will find you every other option. But if you need to have surgery, I wouldn't go anywhere else, so.
I agree with what you're saying. I'm the same way. Like I'm a musculoskeletal doctor, right? So I'm also a surgeon, but I think that I know your body better than you do, right? So I think I can help you prevent that surgery as much as I can do the surgery. And I know Dr. Meyer is saying the same way. Oftentimes patients will say to me, I don't want surgery. Okay, this is what you need to do, right? You're walking this way, you're gonna get surgery. I can help you in the process. Just because we're surgeons doesn't mean we can't help you in the non-operative process. Getting to the operative process is the final stage, and it doesn't always need to be, you know, be all. And I know that Dr. Meyer is the same way as I am. We don't always say, hey, surgery, 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 right? Because it's what's best for you. That's what we want. Dr. Roman.
So today, so I figured I have to say something. I'm Katie Roman, I'm one of the anesthesiologists here and SOSI. I have been an anesthesiologist since 2005 at several different facilities, several of them on the front range. I've worked at high volume orthopedic surgery centers in the past.
And Bobby's
It's
the
been
best.
very comfortable. That's right.
Said Bobby, not that.
And I have to tell you, all 4 members of my family have now officially been patients of SOSI. Dr. Alex Meininger told me I didn't need surgery on my knee, so they don't always just cut on you because they are surgeons and they want to. He got me raised in rehab and I'm doing great with that. But I've always told people that if you want to know who the good surgeons are, you ask the operating room nurses, you ask the anesthesiologist, who they go to is who you want to go to. And I'm very comfortable with all my family here. And I see work with a lot of surgeons.
This has been great, and I hope you guys have been able to glean some things, or if there are more questions, we have info cards or staff members to help. We're available. We're hopeful to put this in video format online, and it can be checked on later if you have more questions. And we want to thank everyone for coming. It's been great. Hope you feel the same.
Yeah, thanks.
I have.